critical care, the head of the critical care department of Apollo Secunderabad Hospital, and they have a lot of critical care experience, including emergency department, and he's also medical superintendent and ISB qualified person. He's a quality in charge, and he's IDCCM teacher, and presently running entire ICU show along with the administration in Secunderabad Apollo with the team of 6 people. And he's very enthusiastic and interested. I've been known to him for last 3 decades, and he's there into critical care for nearly 2 decades and trained in Chennai, and is presently also in a session edo undi sir meeru academic session in kodantlo unnaru sir. So I request Dr. Satish to take over the class. Thank you, sir. Voice లేదు మీది.
Good morning, sir, for your kind words. Today's topic is like we all come across that is almost we are playing a dead end game. Management of a paraquat poison. So last 2 months we got 3 patients. We struggled to manage those patients, and one patient survived, but we doubt that he hasn't taken the poison. Otherwise, dectomy's paraquat poison should die as of now, the available literature. So that patient survived, but we don't take that credit. We give that like he might not have taken paraquat at all, but he landed into renal shutdown and main dialyzed outside, came to us, and we continued the dialysis, and patient went home without dialysis. So the other patients all are died, and we go through the like how the death happened and what we could able to do. So Dr. Chatan is our one of the senior consultant along with me in Secunderabad Apollo. Is FNB critical care. He has done DNB. More than 8 years experience in Secunderabad Apollo. Over to Chatan. Please highlight the overall paraquat poison and its management.
Thank you very much. Good morning to everyone. I'll share the thing. Am I audible?
Yeah.
Sir has already discussed about the paraquat, what are the complications and what are the percentage of mortality so far. So today we will start with one case. A 25-year-old male was presented with multiple episodes of loose stools, vomiting and low-grade fever for 1 day. History of 1 episode of giddiness and breathlessness at 2:30 a.m. Went to nearby hospital, was shifted later to our center for further management. On evaluation, we found that there was a decreased urine output on a history of outside food intake. 24 hours later, in the ICU admission, we revealed a alleged consumption of a herbicide, approximately 100 ml, 2 days prior to the onset of the symptoms. On examination, patient was dehydrated, lethargic, ectric or febrile. Heart rate was around 120 per minute, BP 120/70. CVS S1 S2 normal, saturation he was maintaining around 95 to 98% on a room. On central nervous system, GCS was 15/15 with a slight irritability. On a lab evaluation, we found that our TLC was around 17,000 with neutrophils predominant upon neutrophil. But blood urea 95, blood urea nitrogen 40 per milligram deciliter. Creatinine of 6.46, uric acid of 9.6 with a low bicop. It also showed that a liver function test was altered. Total bilirubin was of 3 milligram with HGOT and HGOT elevated. ABG was showing metabolic acidosis with a high enzyme with an increased lactate level. So he was started on a supportive care in the form of IV fluids, steroids, antioxidant, and acetylcysteine antibiotics. Nephrology opinion was taken. He received a renal replacement therapy for 6 hours. Subsequently, he had an increased work of breathing with a drop in saturation to less than 75% on room. At the same time, he was having a respiratory rate of around 50 per minute with use of accessory muscle. So he was given a non-invasive ventilation with a FOUD of 21% with a pressure support of around 10 with a PEEP of around 6. So patient subsequently intubated, connected to ventilator and a volume control mode. So in view of a refractory hypoxemia and hypotonic, patient had a bradycardia followed by assist. CPR given as per the SCNS guideline, ROSC could not be achieved. Unfortunately, he succumbed because of a multi-organ dysfunction. So what is Paraquat? It's a pesticide poisoning. It's a major public health issue in the developing countries. Approximately around 2.8 to 3.2 lakhs per year estimated death in Asia Pacific. India is a leading pesticide killer as it is relatively inexpensive, first time discovered in 1955 as a rapidly acting non-selective contact herbicide. It was widely used as a bipyridal agent and is essential component of weed control in many agriculture, in horticulture and forestry. So coming to pharmacology, it is a N-dimethyl 4,4-bipyridine dichloride, also known as a methyl biologen, is an organic compound with a chemical formula of C6H7N2 chloride. Classified as a biologen, a family of redox active heterocycles, non-selective. It is non-selective and quick acting, kills green plant tissue on contact. It is also toxic to human beings and animals due to its redox activity, which produces superoxide anion. Only 20% of ingested poison is absorbed by stomach. It has high volume of distribution, rapidly distributed to highly vascular organs, especially lung, liver, kidney, and muscle. This is very important. The redistributes back to the blood relatively very slow. That is the toxic level in tissue occurs early in the course of the poisoning. It is not metabolized by body and is excreted unchanged by the kidney. Initial elimination half-life is around 6 hours, but this is around, you can extend up to 4 days after the first 24 hours. So coming to mechanism of toxicity, Paraquat concentrates in the lung, mostly in the pulmonary alveolar type 1 and type 2 via energy-dependent transport system. Because of a structural similarity of Paraquat with naturally occurring polyamides taken up by the alveoli, it is actively secreted in the kidney, organic cut and transport system, saturated at a higher concentration, leading to accumulation of proximal tubular epithelial cell. This leads to the high accumulation of a concentrated Paraquat, leads to a redox cycling and generation of toxic reactive oxygen species. This overall cellular defense mechanism are linked to a lung damage due to rapid and excessive proliferation and differentiation of a fibroblast, resulting in a loss of pulmonary artery. It also causes renal tubular necrosis due to accumulation in the cells of a proximal convoluted tubules. Coming to the pathway, if you look at a Paraquat ion PQ2 gets reoxidized inside the cell and forms a PQ2 with the form of a superoxide oxygen. This superoxide oxygen converted into a free hydroxy radical by the Fenton reaction, leading to oxygen-free radical, which will lead to a glutathione oxidation, depletion of a sodium NADPH, as well as a structural and enzymatic protein abandonment. It also has a lipid-free radicals, leads to disruption of lipid membrane integrity and degeneration of membrane organ, leading to cell death and multi-organ failure and dysfunction. Coming to clinical presentation, it will vary depending on the organ involvement. At skin, it will have erythema, eruption, boil, ulceration of the skin, excessive inhalation of aerolized Paraquat leading to stomatitis, epistaxis, sore throat, and headache. Eyes, it will cause local inflammation and ulceration to conjunctiva and cornea and diminution of it. GIT, nausea, vomiting, and diarrhea, ulceration of the tongue and mouth, which is also called as a Paraquat tongue, sloughing or oropharyngeal mucosa and severe cases will lead to perforation of esophagus and mediastinitis. Just look at the picture. In the early lesion, if there is a lesion in the first 24 hours, if patient survives in almost 3 days or less, 1 week, it will develop the ulceration and bleeding of the tongue, which becomes difficult for swallowing. Renal will have acute tubular necrosis in 1 to 2 days. Patient may have oliguria or a non-oliguric AKI. With CV examination will reveal a microscopic hematuria, proteinuria, glycosuria, phosphaturia, amino aciduria, and excessive leakage of sodium urine. pulmonary cough, hemoptysis, and rarely pneumothorax, pleural effusion, or pulmonary edema. In substantial ingestion, if you have a ARDS, chest X-ray will be appear normal initially, but will develop a patchy infiltration, progressive opacification of one or both lungs. Now 1 week to 2 weeks. Survivor will show restrictive type of a pulmonary dysfunction. Liver, it will often have a ictus, hepatomegaly, and rarely pancreatic cardiovascular, sinus tachycardia, ventricular tachycardia, non-specific TV changes, and intraventricular conduction defect. Terminal event is often hypotension, bradycardia, followed by cardiac. Neurologically, patient in severe poisoning, it will cause cerebral edema, manifesting with ataxia, convulsion, facial paralysis, and finally coma. Endocrine adrenal cortical necrosis in severely poisoning which cause multi-organ failure. This may be the main reason why a patient is going into a refractory hypotension. Hematological polymorphonuclear leukocytosis, normochromic anemia, and hemolytic anemia. Metabolic elevated CPK level, hypercalcemia, and a metabolic acidosis. And this is one more classification of poisoning of paraquat depending on the quantity of ingestion. If the quantity of ingestion is less than 20 milligram or less than 7.5 ml of 20% concentration, which comes under a mild to moderate, will have a nausea, vomiting, diarrhea, abdominal pain, mucosal lesion, ulceration, rolling, or dyspnea. Your outcome will be very good. There will be a complete recovery we can expect in such cases. In more severe, 20 to 40 milligram per kg with 7.5 ml to 15 ml of a 20% severe, 0 to 4 days clinical dyspnea, hypoxia, ARDS, hypotension, renal failure, hepatic failure, 1 to 2 weeks, hemoptysis, pleural effusion, pulmonary. Survival possible, but majority of this patient will die within 2 to 3 weeks because of extensive pulmonary fibrosis. Fulminant or fatal if the ingestion is more than 40 to 50 or more than 50 25 patient will have ARDS, myocarditis, renal failure, adrenal gland necrosis, hepatic failure, metabolic acidosis, severe coma. We expect death within 1 to 4 days in such type of patient. Management, as we know, it's a ABC protocol. First, we like to decontaminate as soon as possible by removing contaminated clothes and washing skin thoroughly with soap and copious amounts of water. Happy may be compromised because of a mucosal toxicity or the presence of vomitus. So we had to put a airway or suck out the vomiters or do a suction. Tachypnea and hypoxia may be due to metabolic acidosis, aspiration, or alcohol, which we need to do a blood gas and chest radiography. We have to correct the diagnosis. Mild to moderate hypoxia should not be routinely treated with oxygen as it will worsen the oxidative state and increases the lethality. Hypotension may be there in the initially, which can be managed by giving a bolus of fluid around 15 to 20 ml over the and can be reported as necessary. Renal failure may be expected enough because of it is excreted via kidney. So close monitoring of fluid balance is needed. Patient generally will maintain a normal level of consciousness. Severity of toxicity may increase, leading to a altered consciousness from hypoxemia, hypotension, and acidosis. It is worth emphasizing that intubation and mechanical ventilation are futile in severe cases of paraquat poisoning. When to analysis of diagnosis, it can be analyzed in a qualitative or a quantitative measurement. Qualitative is just urine spot test, where we need to alkalinize urine with sodium hydroxide, getting the pH around that, and using a sodium diethionate as a crystal, which will possible. If it is more than 1 milligram per liter, the urine will appear as a blue or green. And this indicates that it is a very poor prognosis of a survival. In case in the initial evaluation, you can do the urine test. If this negative can be repeated every 6 hours post injection and still negative, then the serious complication or sequelae are unlikely. Quantitative measurement is very important. Plasma paraquat more than 2 milligram per liter indicates poor prognosis. And here the sample must be taken within 4 to 5 hours of a post injection and should be stored in a plastic, not in a glass. Plasma paraquat is more important than the serum paraquat because the serum paraquat concentration are approximately 3-fold lower than those in the plasma. Going to investigate, in addition to paraquat concentration, biochemical investigations such as electrolytes, renal and liver function hematology should be done at least daily. Chest radiograph should be performed with pneumomediastinum, pneumothorax, or a lung fibrosis. HRCT scan may be useful in detecting early lung fibrosis or assessing long-term damage in survival. Mileage and lipase may diagnose acute pancreatitis shall be suspected patient develop abdominal pain due to raised blood sugar. Such X-ray which appears in the beginning around 1 week, which the patchy infiltrates all over, and you can see the CT scan which it's fibrosis in 2 weeks time. With relationship between paraquat plasma concentration survival. A draw x-axis where the hours after swallowing we mentioned and the concentration of plasma paraquat. It denotes the percentage of probability of survival. The survival of probability will be very high if the intervention is done in the first 4 hours because the paraquat concentration levels are level. As the time passes on, its survival of a possibility of from paraquat poisoning diminishes. It diminishes 70%, 50 to 30%. As the time passes on. Elimination of the toxin. Gastrointestinal decontamination, gastric levels should be done as by dose activated charcoal, which is recommended within 1 hour of ingestion. As paraquat is life-threatening with no antidote available, single dose of activated charcoal or floats are recommended for consenting patients who have protected. No recommendation of gastric lavage as it is contraindicated in caustic injury. Extracorporeal elimination. Whether it could be either in the form of a hemoperfusion or a hemodialysis. Hemodialysis is indicated only when there is an acute kidney injury or a liver failure, but this will not eliminate the paraquat poison which is present in the blood or plasma. At the same time, clinical monitoring and ongoing care, acute renal failure, maintain a good urine output without overloading the patient. Liver toxicity, clinical examination should be done every day. Detect any jaundice or right hypochondria. Respiratory failure, monitoring respiratory auscultation of the lung, measurement of the peripheral oxygen. However, supplemental should not be given except as a palliative measure. Patient determined to be terminally declared. Mucosal injury, patient develops several ulcers such as paraquat within a few days after injection. This generally prevent patient from taking adequate food or oral fluids for appetite. So early insertion of nasogastric tube will be ensure adequate pain relief with opioid is often required. Just a summary of early management. There is significant paraquat injection suspect history. There is a vomiting, you can control the vomiting in the form of ondansetron 8 milligram. There is no vomiting, then you can give activated charcoal if the patient comes within 1 hour of injection. General early management, IV fluids, avoid supplemental oxygen if possible. The paraquat spot test in the form of urine and gastric is negative, repeat after 6 hours. Even if it is negative, then you can discharge the patient. If it is positive, then plasma paraquat level is important. It should be collected between first 5 hours. So this will detect the survival probability curve with the more than 2 milligram per liter. If the patient is very sick and not going to survive, it's better to suggest palliative care for those patients with analgesic and supported renal function. Coming to the hemoperfusion, which is the important chapter in this discussion, extracorporeal blood purification modality that consists of the passage of anticoagulated whole blood through a device, usually common that contains fixed lots of particles. It has varied absorption properties due to engineering of the porous structure. Toxins with molecular weight ranging from 100 to 40,000 Dalton bound particles and are. The binding is through physical absorption, which is governed by the molecular size and the lipophilicity. The absorbing column, we can have a broad spectrum absorption or a selective spectrum absorption. So broad spectrum is cytosol, coupled plasma filtration and absorption. HA230 absorption and peroximexin. I will be talking more of a HA230 as a selective because at the same time activated charcoal is also available, but there are drawbacks with the activated charcoal. What are the indications various poison which can be used. And drug overdose, benzodiazepine, barbiturate, carbamazepine, digoxin, metformin. Biotoxins such as apitoxin, snake venom, mushroom poisoning, pesticide and herbicide, it's acute organophosphorus poisoning, paraquat. Denticide, tetramine, and bromadiol. Industrial toxin, industrial alcoholism, 2,4-dinitrophenol. Why HA23? This is because it ensures a good efficacy and safety. It has a large absorptive surface area, high mechanical strength of adsorption, resin material with advanced coating technology, optimized hemodynamics, and filter prevents particle detachment into body. So difference between HA230 and charcoal cartilage. The presence of the property of adsorbent HA is neutral microbial resin, whereas it is activated carbon. Pore size is average is around 30 to 15 nanometer. There is no average pore size. Absorption spectrum relatively specific absorption. It is non-select. Targeted molecule middle to large molecules and a protein bound substance. Small to middle molecule substance. Safety is the main reason why HA23 is preferred over charcoal cartilage. Resin reads in same size, smooth surface, strong and good blood compatible. Whereas it has natural material, hard to control size and surface, hard blood surface, which is harmful to platelets. Weak skeleton may break off and form embolism. So what they recommend as a hemoperfusion is early initiation with HA23 filter within 6 hours of a injection. And they suggest to give a 2 to 3, 4 session of a hemoperfusion along with hemodialysis renal involvement. And they do about 2 sessions of a hemoperfusion on a day 1 session on day 2 and day 3. So that each hemoperfusion may last for a 6 to until plasma carotid levels be less than 0.2 milligram per liter. So some benefit about they are removing the overdose of a drug and poison its paraquat level. As this one, it's a baseline which will control a hemoperfusion and a group of hemoperfusion which is severe. 24 hours, definitely there is a drop in a level for paraquat concentration in blood. As of time passes 71, there is a significant drop in this P value of less than 1. And it also shown a therapeutic effect, improving the decrease in a SOFA score by 72 hours. This is a time concentration of paraquat. It is after injection. This black line indicates that the plasma concentration, red line indicates the lung concentration, and dotted line indicates the tissue concentration. So normally when there is an injection, the blood plasma goes up, but there is a lung concentration remains on the higher side because of a slow redistribution of the poison in the blood. So if you do a hemodialysis along with the hemoperfusion in the first 6 hours, there is a decline in the lung concentration from almost 4 to 2.5. But this should be done in a 2 to 3 sessions per day in the first day, because it is a slow as the plasma concentration comes down. After 24 hours, again it picks up. So if you do it after 6 hours, the elimination of a concentration of a paraquat from the lung is very slow compared to the hemodialysis or hemoperfusion done within 6 hours. So this represents how it takes slow elimination of a concentrated plasma concentrated paraquat from the lung. So this is a golden hours in first 6 hours early reperfusion. Case we have done the retrospective analysis of patient admitted to a tertiary hospital in 2012 and 2015. So what they have done, they have started one group of patients with only gastric lavage and symptomatic treatment, and those we received with the hemoperfusion. So we have done the divided into 2 groups, and the early perfusion it is less than 6 hours, and the late perfusion more than 6 hours. And what they found out in 101 patients started off is 62 died. Deaths were more in those patients who received only gastric lavage and symptomatic as compared to the therapy who received a hemoperfusion. That is around 42.9% as compared to the 19 supporting. So they also found that survival rate was better in patients who received early perfusion. So that is why, based on this, we can say that it's better to start a hemoperfusion as early as possible to have a better survival rate. Pulmonary fibrosis. This is a important and challenging thing to manage because of redox cycling and oxidative. So what they found is somehow they have found to have delayed the time of a pulmonary start of survival rate. And so what they have done is cyclophosphamide steroid therapy exercise immunosuppressant cyclophosphamide up to 1 gram per kg 1 gram per day for 2 days, followed by injection methylprednisolone 1 gram per day for 3 days, and overall dexamethasone 8 milligram 3 times a day along with the antioxidant. As a vitamin G 300 milligram twice daily per hour, vitamin C 300 twice daily to reduce free radical toxicity, N-acetylcysteine 150 milligram per kg over 3 hours, 300 milligram per kg over 21 for up to 3 weeks to increase intracellular glutathione, desferrioxamine 100 milligram per kg over 24 hours, chelate iron which acts as a catalyst in the production of a hydroxy salicylic acid which can scavenge hydroxyl radical and inhibit the activation of natural and kappa B factor. But there is no proper evidence available. This is all experimental study. There are 4 or 5 studies which they have seen that it has decreased the mortality by 28, one study 33%, 63%. So they have shown that there is a decreasing, but there is no follow-up. Some of the study has not been, a follow-up is not done properly, whereas Paraquat measures are not done properly. Some studies, they say sample size and power calculation not much, so no follow-up after. So so these are the drawbacks of this thing, but there is no confirmation on randomized controlled trial available so far. The recent advances is edaravone is actually a neuroprotective medicine. It is a free radical scavenging antioxidant, which also has an anti-apoptic, necrotic, and anti-inflammatory effect. In 2019, Bai et al. From China published a retrospective study on the use of edaravone in the treatment of Paraquat poisoning, found to be beneficial for protecting the kidneys and liver from Paraquat poisoning by reducing oxidative stress and inhibiting inflammatory response. Edaravone did not reduce pulmonary fibrosis in patients with Paraquat poisoning, but delayed the generation and development of pulmonary fibrosis. Edaravone prolonged the survival time of a patient, but had no significant effect on the survival rate. The last is the role of extracorporeal membrane oxygen. Tang et al. In 2015 reported a successful extracorporeal membrane oxygenation therapy as a bridge to sequential bilateral lung transplantation for a patient after severe Paraquat poisoning. Extracorporeal membrane oxygen has been tried in such type of poisoning for lung. However, lack of evidence and cost effectiveness at this point hinders its recommendation in the treatment of Paraquat poisoning. Summary of a treatment recommendation. One is the decontamination. It should be done within 2 to 1 hours. Use activated charcoal of nasal plastic tube indication because of a Paraquat tongue or advanced. You can use Paraquat poison for analysis for this. Insert prophylactically as possible as swallowing becomes difficult later. Urine diethylamidase is very important. It will indicate prognosis and survival if you get plasma Paraquat for all patients indicates prognosis. Routine investigation, monitor fluid balance, intravenous fluid, hemoperfusion, hemodialysis should be done within 2 hours. If there is a renal failure, it should be started with a renal replacement. It's likely to fatal in severe. Monitor respiratory rate and oxygen. Try to avoid oxygen as far as possible, and target SPO2 is around 80 to 85% saturation. Look for a treatable causes if there is any infection, pneumothorax, pneumonitis, or fibrosis. Monitor cardiovascular system, see if hypotension is responding or monitor level of consciousness in all patients if CNS is secondary to hypoxemia or acidosis. Pain relief and sedation. Intubation and ventilation acute state as for any as for any other medical condition, look for any pneumonitis. Because due to large injection, it can lead to lung fibrosis. Experimental therapy, what I have discussed, also, there's no evidence of human trial on this. It's just animal model which supports this. To conclude, it is a leading cause of death in more than 50%. It is highly toxic to human, leading to multi-system involvement. There is no specific antidote available for treatment till now. Lungs have been affected due to high concentration of a paraquat. Oxygen supplementation will further worsen oxidative stress. Extracorporeal elimination should be considered as early as within 1 to 2 hours. It is important to establish diagnosis as early as possible to perceive aggressive decontamination and prevention of further adsorption. Increased awareness of clinician and availability of diagnostic methods will definitely help in successful management. So with this, I will conclude this my presentation. Thank you.
Thank you, Chetan. It's a very elaborate presentation. And we were in like thinking of how Paraquat, is there any possibility of extracorporeal membrane oxygenation? ECMO can be like useful, but we understood that it doesn't have any direct influence. Only
Even if you use a ECMO and try to the paraquat is concentrating in the lungs. So even if you try to do aggressive perfusion and try to go for a lung transplant, even in the early stage, from the allograft lung will also get spoiled with the formation of a pulmonary fiber because it is concentrating, excreted in the elimination is very, very slow from the lungs. So ideally they take almost 32 to 40 days for this to settle because still the plasma paraquat level comes to less than 0.2 milligram per less. So then only they will take off depending on the survival.
Thank you. And thanks, a very good presentation. And I request any questions or any further discussion on this, seniors and rest of the people.
Few questions can I ask, Sadish?
Please, sir.
Yeah, as Dr. Chetan Shirurg was mentioning in the slide, saying that the lung concentration, putting on the heme absorption, the concentration has come down, but it is not reflected into the mortality. Am I right, Dr. Chetan?
Yeah, it comes down, but because of a slow redistribution from the tissue level, so then it remains almost takes time because of the slow redistribution.
What is the amount required paraquat for a person to die?
More than 15 ml.
More than 50 ml. Even a moderate amount of so basically it is not metabolized. So whatever small quantity is taken, it is absorbed, and whatever paraquat present along with the cell lysis or in the form of enzyme, it gets converted into paraquat, which will oxidize in the cells itself to convert into a oxygen ready superoxide oxygen.
So as you said, one patient survived, no?
One patient was survived because this patient has taken a very minimal quantity and there is a doubtful what Saur is telling that doubtful consumption of that. But this patient was dialyzed in the peripheral center immediately. He was dialyzed and he was shifted to our higher center for further management after 2 days, 3 days. So he received 2 to 3 sessions of hemodialysis in the peripheral.
So one theoretical question, as you said rightly, if we put the patient on ECMO when the patient comes to the with the consumption of paraquat poisoning, and put him on ECMO for, as you said, maximum of around 40 days or 48 days. So you put the patient on ECMO for 50 days, 50 or 60 days, 2 months, then you go for lung transplant. Is there any chance of that?
That depends on how much concentration for plasma paraquat is there. If plasma paraquat is there more than a 0.2 milligram per liter, what they have suggested that should be minimum cutoff point. Then we can suggest the patient to go for a lung transplant.
But lung transplant can be done only after 60 days because again,
Exactly.
that lung also will get fibrosed, you are telling, no?
Yes, sir.
Yeah,
Yes.
one more thing. Recently, some WhatsApp groups and all, we listened that lot of paraquat poisons are survived because of their treatment in Vijayawada Ramesh Hospital, they're telling. So, because my experience is very bad of paraquat, I don't have a belief that paraquat fellow will survive. But what is it? What, because your patient also once survived, or is it like, like a quality of drugs? The quality of paraquat poisoning is bad, so that's why the people are surviving. Or what is your take on that, Dr. Shirodkar?
So basically, if patient goes to the hospital within first or most of the cases are self-poisoning. If self-poisoning happens, none of this patient will go to the reveal that has happened in this case. Revealed after 3 days or 4 days that he has consumed paraquat. By the time he has already end of the life. So if the depends on the quantity of paraquat what they take. If the
No, I agree quantity. What I'm telling is even if you take quantity is around only 15 ml, and if you come to the hospital immediately, so can they survive?
survival will be more if it reaches a hospital within 4 hours. This
We should
hospital
reach
has
within
got a
4 hours.
facility of hemoperfusion and as well as hemodialysis.
Sir, Mohan sir,
Chappan Satish garu.
the survival is decided by three factors, sir. How much amount consumed, how early reached the hospital, and how early we instituted the rescue therapies like heme absorption or like extracorporeal removal of the toxin. So these three are important. So most of the times what happens is the patient comes to any hospital. If he desaturating, first thing knee-jerk phenomenon is we will keep him on oxygen. One thing. So that is actually should not be done. But by the time we know that whether what he has consumed, he might have received oxygen which worsens the lung toxicity. First thing. Second thing is how rapidly, see, organizing a dialysis and patient who came to emergency, minimal in my hospital it takes 6 hours. So that is one thing. Second thing is we are not sure how much he has consumed and what percentage he has consumed. Most of the people, they don't take directly the Paraquat 20%. They mix it with alcohol. So something will be done like that, but we are not sure of what percentage and what quantity actually consumed. So theoretically, I have read in the up-to-date and other literatures, if it is up to 10 ml and immediate interventions are taken place, survival is very good. If it is more than 30 ml and patient got delayed to institute hemodialysis after 24 hours, the survival is very poor, sir.
Second thing, there is no randomized control trial available for this paraquat till now. So what is how much will benefit survival benefits? It's a single case reports are coming up.
Have you seen that literature or whatever the material they talked about from Ramesh Hospital, Vijayawada, they're telling so many cases survived?
Sir, those cases, sir, Monson, those cases are patients who were treated in the early hours within 6 hours, and the amount was they were quoting it like 15 to 20 ml.
How much they were quoting, Monanga?
15 to 20 ml, I think, average. And they're doing a HA230 filters for around 3 to 4
Yeah,
sessions,
that's what.
and as per the requirement, and
Yeah.
depending on the urine
Okay. I think you know about that cases, kada, Srinivas?
yes, Dharmendra. I know
Yeah.
him, sir.
So, okay. Thank you.
And there is a recent case which was also posted in the group, the same group you are saying, who was consumed around 50 to 60 ml, and he is all right. And I think he's 8th day of the post injection or like 10th day of post injection, and he has received again 3 sessions of dialysis, and they are planning to discharge in next couple of days.
Hello?
Satish Chappande.
Yes, sir. So thing is how honestly we are presenting that case. See, I clearly told that we have one patient who got survived with Paraquat, and we give that credit to the amount he consumed, not to our efficiency.
Do every year person knows that not to start oxygen?
And we actually displayed, sir. We displayed that if the patient is hypoxemic, take the history of any poison consuming, and any doubt, don't give oxygen. We displayed in the ER. There is a pamphlet.
Any doubt of only Paraquat or anything else?
We basically started this only with, because we are more considered about Paraquat, because in Hyderabad, Paraquat poisoning is coming up. Like last 2 months, I've seen 3 patients.
Thank you, sir.
Sir. J. Srinivas, sir. Sir has experience. I think one patient kept an ECMO also.
Good morning, sir and Dr. Satish.
Morning, madam.
Actually, we had one family, full family, that mother poisoned both 3 kids, I think.
Wow.
And she also consumed. And by luck, one daughter survived who was just 5 years. And then, they succumbed to death only after 2 to 3 years. Initially, we everything hemoperfusion, that CRT was started initially only as soon as they came in the midnight. But that child survived, and then, like, there was out of the doubt, all the sisters were and we were asking that child, did you take it, did you swallow it? And then she was telling that I did not swallow it, I threw it out, spit it out. That's what she told. Maybe that is the reason, like, whoever have survived, they might have not swallowed it.
Exactly. Yeah.
And that one few months old child, like it was just 7-8 months old child, maybe that might the child cannot do anything, that might have swallowed it.
Yes, ma'am.
It was fight between husband and a wife, and she poisoned everybody.
Really pathetic situation. I don't know why Indian government is not banning this paraquat. If you see that what Manjula madam has described now, so she has given to both child and she took herself. And so many the last 2 years, I think, Mohan sir, we have seen so many cases, but most of them are late presentations. That is the big problem.
Whatever we are in the fraternity of ICU as doctors, we are very helpless. We are really not able to do anything. Maybe I don't know how to really just few things we say that how to really help these people, because when they are preparing any treatment for anything, when they give, normally they give antidote. And what antidote they have given here? Because any items like, for pharma industry, when they're preparing, they write antidote below and normally put it. I don't know what the antidote they have written also. I also don't know. I really don't know.
There's no antidote for Paraquat.
Sir, why can't we discuss in the ISCCM forum, because you are one of the EC, and can we push the government to ban this medicine?
Yeah, we can actually. What have to do is every city, everybody has to write to the government, the collector writing one. This is a big, we have to take this seriously and consider something like whatever it is. I don't know.
It's banned in 2 states, sir, in India, Kerala and Tamil Nadu.
So nice.
Paraquat, it's actually, we got quite a few cases, so I have done some research on this one. So Europe law, since 2007, it's banned in Europe, sir. Around 48 countries in the world have banned Paraquat. So there are some in India, Kerala and Tamil Nadu are the 2 states which have banned Paraquat. This data is as of 2021, sir. Any recent states added, I don't know. But there are alternatives suggested to Paraquat, like they contain both herbicide and non-herbicide methods. So herbicide, they have actually suggested few synthetic Paraquats, though they are not so effective as Paraquat in killing the herbs, but again, they are equally not effective in killing humans too. So glyphosate is one of the synthetic herbicide alternative to Paraquat, whereas Paraquat has nearly 100% mortality. Glyphosate, if not mixed with any other ingredient, has got only 7.7 mortality. And also there are like non-herbicide methods like living mulches. They something like they cover the as a covering crop, something we will be there. And controlled grazing, mechanical weeding and thermal weeding, all these methods have been suggested as an alternative to Paraquats. One more change what I personally observed is around 5 to 6 years back, these cases, they used to be stable for around 5 to 7 days. They used to be completely conscious or no renal impairment and all. But over the past 1 year or so, they have been cases with deterioration, like on first day, on second day, like that. They're presenting with cardiac arrhythmias. So, and renal impairment, they're coming very fast now. I don't know what's the exact reason for this, but before, like 4 to 5 years before, we used to see cases they're very much stable in the first week. Second week they used to deteriorate. So we used to explain the attendants that first week they will be fine. The real problem will be in second week. So you cannot be sure of the survival of the patient like that. But past around last 6 months or 8 months, we have seen around 7 to 8 cases. All have got symptoms on day 1, day 2, like that. And we have done with HA230 filters in 3 cases, sir. They didn't survive, but we have done dialysis with HA230 filters. The main problem again will be timing of the admission, and reliable history again is an issue in these cases. And the rescue therapy, and as Sir was mentioning, starting on oxygen in peripheral center, they shift with oxygen mask on. So quite a damage has been done by the time they come to hospital and all. That's our experience.
As per the first slide of Chetan Shirodkar, I think it's 3 million people or 2 million people dying in India, Dr. Chetan.
It was in a Asia Pacific region, sir.
And sir?
Says per year, sir.
How many?
2.8 to 3.2 lakhs per year in the Asia Pacific region.
Okay. So it's not a big number if you consider.
సార్ మార్కెట్ తో పోల్చుకుంటే అది చాలా చిన్న నెంబర్ కాబట్టి వాళ్ళు బ్యాన్ చేయరు.
అంటే టోటల్ ఏషియన్ కంట్రీస్ అన్ని కలిపి 2.5 lakh అంటున్నారు కదా.
అవును సార్, అవును సార్, దాంతో వచ్చే మార్కెట్ ఎక్కువ కదా.
సార్ అంటే అది రిపోర్టెడ్ డేటా కదా, అన్రిపోర్టెడ్ డేటా చాలా ఎక్కువ ఉంటుంది.
అది పాయింట్. దట్స్ వాట్
జస్ట్ లైక్ కోవిడ్.
మీరు ఎంత కంపేర్ చేయండి, మీరు అన్ని నెంబర్లు పెంచండి, ఫైనల్లీ కమ్స్ టు ద పాయింట్ ఆఫ్ మనీ. అది వచ్చినప్పటికీ ఇంకేం కనిపిస్తుంది. ఇఫ్ యు ఆర్ గెయినింగ్ thousands of crores, so nothing matters.
Yeah.
There has been again a survey in 2021 where actually the agricultural department or the government concerning one, they gave permission to use Paraquat as a herbicide, for only 9 crops, sir. But as per that survey, in India, the farmers or whoever is using that one, they are using for 25 crops, which is clearly violating the regulations. But just like any other thing in our country, it happens.
So, any discussion more? JS is not, no, Sinwas sir is not there, it seems.
Hi, good morning. Hello.
Madam, good morning, Chappandi.
Morning. I think recently, if I remember, we got a case who was treated outside, had saturations in 80s and kidney failure. He was getting dialysis. He needed some more dialysis, but not very affordable. They asked if he can get cured and off dialysis and all. We said no, he need to be continued on dialysis. Though he was maintaining on 80s saturation. So they stayed for a week, I think. Srinivas, are you there? I think they stayed for a week and they said they'll get discharged, and if only dialysis, they'll get it done intermittently. So do you think that way patients can prolong for some more time, or will they live or die eventually? Don't know. That patient went lama.
Doubtful paraquat అనుకుంటా, కన్ఫర్మ్ హిస్టరీ కదా.
కానీ he had desaturation also కదా.
Yes, అవునవును. Desaturation ఉండింది, బట్ అంటే హిస్టరీ వాస్ నాట్ కంప్లీట్ యాక్చువల్లీ.
Yeah, 80s లో అలాగే ఉంది. We didn't put
ఉండేవారు
oxygen.
yes అంటే అది చూసే క్లినికల్ హిస్టరీ చూసే we thought of Paraquat more.
గుడ్ మార్నింగ్ సతీష్ సార్.
సార్ మార్నింగ్ సార్.
ఉన్నాను ఇన్ అండ్ అవుట్ ఆఫ్ ద దీంట్లో. నైస్ టాక్ మేడం, చెప్పండి మేడం. వి హ్యాడ్ ఎ ఫ్యూ సర్వైవర్స్.
ఎవరైనా అలాగా will they continue on dialysis and survive? People can manage with 80s saturation kada, unless they do really active works and need more metabolism unte tappa. If they just sit at home and not doing much work, like 80s should be fine. Alagundi dialysis meeda can they manage? Can they survive for how long? Anybody? Any answers?
Good morning, ma'am, and good morning, all. Actually, ma'am, we have seen that by 4th or 5th day, if they are, they usually deteriorate. Whatever you do.
What we have seen is after 10 days or 2 weeks, they came to us.
That I don't know, ma'am. But whoever had, initially they'll be not having hypoxia and all, but in spite of that, the hemoperfusion and CRRT was done. And then by 4th or 5th day, they usually become serious and hypoxia worsens. And then whatever you do, they have not survived in our hospital in Medical, like whatever 7-8 patients we have. If it is after 1 week or 10 days, I think it may not be because of that. Purely.
No, in the literature, what it says is they'll deteriorate up to 23-4 weeks. They may prolong, they may drag on, because as Dr. Chetan said, they may be like a poison coming out of tissues, like again and again it will circulate in the body. So that will be there.
So he has mentioned the same thing, no? Chetan, can you reaffirm that? How frequent you have to dialyze? Chetan, if hypoxemia is not a big deal, how long we have to dialyze the patient?
Basically, it will take till the level of the Paraquat comes down to plasma less than 0.2 milligram per liter.
Sustained low level values in the blood.
Yeah.
Till that point, we have to dialyze the patient. If their respirations are not an issue,
Yeah.
continue daily dialysis and see that ultimately long term the blood levels are maintained less than a particular value of the Paraquat levels.
This is the reason why.
అంటే సార్ ఇది డయాలైజబుల్ బికాస్ యూజువల్లీ ఇట్ ఈస్ అంటే ఇనీషియల్ గా ఫస్ట్ విత్ ఇన్ 6 hours లో పనిచేస్తుంది కానీ బట్ వన్స్ పేషెంట్ బాడీలో అబ్జర్వ్ అయినాక కిడ్నీ ఇంజురీ కానీ లంగ్ ఇంజురీ అయిన తర్వాత డయాలసిస్ విల్ నాట్ హెల్ప్ నో సార్.
No, sir. We have to take out the drug by doing that.
Hemoperfusion as well as both three of it.
There is a specific filter, sir. One filter, we use that and we do. It's not a simple dialysis, not what we do for AK or CKD. We have to do is a extracorporeal therapy, trying to target the decrease the plasma levels of the Paraquat. That's all.
అంటే అట్లా కాదు
సార్ అదే యూరిన్ డైటనేట్ టెస్ట్ చూసి ఇఫ్ ఇట్ ఈస్ పాజిటివ్ దెన్ స్టిల్ ఇట్ ఈస్ ఎక్స్క్రీటింగ్ త్రూ కిడ్నీ అని కన్ఫర్మ్ చేశాక దెన్ నెక్స్ట్ టెక్స్ట్ విల్ బి అంటే నెక్స్ట్ డయాలసిస్ విల్ బి బెనిఫిషియల్, లేకపోతే లేదు.
అట్లా కాదు సార్. హియర్ 2 things. One is once absorption is over and leading into the injury, lung organ injury, అట్లానే పేషెంట్ వర్సన్ అవుతున్నారా లేదా బికాస్ ఆఫ్ ద levels in the body continuously increase levels in the body వల్ల
ఇంక్రీజ్ లెవెల్స్ ఇన్ ద బాడీ అంటే టిష్యూ అబ్జర్ప్షన్ కూడా ఎక్కువ, వాల్యూమ్ ఆఫ్ డిస్ట్రిబ్యూషన్ ఎక్కువ ఉంటుంది కాబట్టి when you are decreasing the blood levels, third spacing అంటే ఆ వాల్యూమ్ ఆఫ్ డిస్ట్రిబ్యూషన్ ఉన్నది కాస్త బ్లడ్ లోకి వెళ్తుంది. సో దెన్ యూ రిమూవ్ అగైన్ స్లోలీ. ఒకసారి బ్లడ్ లో కాన్సన్ట్రేషన్ తగ్గాక బయట టిష్యూస్ లో ఉన్నదంతా బ్లడ్ లోకి అబ్జర్వ్ అవుతుంది. బ్లడ్ లోకి యూ ఆర్ టేకింగ్ త్రూ హిమోపర్ఫ్యూజన్. Again, once the concentration decreases, again you చుట్టుపక్కల ఉన్నదంతా వస్తుంది. Probably this is the mechanism.
Anything, sir? Shall we end?
Sir, we actually did stem cell also for one Paraquat patient. He survived.
Madam, please explain, madam, what you have done.
Actually, this was an elderly man, actually with very doubtful history, but typical presentation. He was a sort of a sannyasi kind of a person who had some psychiatric illness as well, consumed some unknown poison, brought to our hospital from an outside hospital. One session of hemodialysis was done there, not hemoperfusion. Subsequent to that, patient actually came to us around 18 hours ish since consumption after one regular hemodialysis. So this man had multiple comorbidities. So we did hemoperfusion twice. In the meanwhile, stem cell therapy was also administered to this patient. So we did 2 sessions. And then this patient subsequently, he was actually not hypoxic, but he had lot of oral bleed and he had a deterioration in his consciousness. So we intubated him for airway control. So we ventilated him throughout for a period of about 5 to 6 days on room air.
There is no hypoxia, ma, intubated for
There's no-
ventilation control.
No, that's the reason I doubt Paraquat, sir. Whether it was being attributed to all the interventions that we were doing. In the sense, no hypoxia, in the sense 90, 91, 92, those kind of saturations. Never less than 85, 86. So that was his status. So this man subsequently improved. We thought the moment we did stem cell, and then his bleeding parameters and all improved. So we extubated him, and he walked back home. And he comes for follow up, and sort of the person who got the idea was made a hero. But I seriously don't know if we can attribute, first of all, whether it was Paraquat at all, we don't know. The amount that he consumed, he never told us, even after he became conscious and responsive. So I don't know, but we did this. We did hemoperfusion. We did like was prescribed. We did hemoperfusion 2-3 sessions, almost in the first 24 to 48 hours, and then subsequently we continued hemoperfusion with hemodialysis. No CRRT, not much hemodynamic compromise, very minimal hemodynamic compromise. Myocardial function was preserved throughout almost. This patient walked home. And pre hemoperfusion era, I've seen almost close to 30-35 patients during stint at NRI first when I was doing my IDCM, then 3.5 years as assistant professor, and then when I was doing my DM, close to 30-35 or even more than that cases that I can remember. In the first phase, nobody lived, and I've seen through all phases, like what Dr. Chetan described. Day 1 dying because of severe myocardial dysfunction, frank pulmonary edema, cardiogenic shock kind of a picture, and dying, to those presenting very late. But generally, the patients that we saw, if they survived the first week, then generally it was a multi-organ failure kind of a situation where they also developed transaminitis and liver failure. And then bleeding diathesis, along with compromised renal function and pulmonary function as well. So the entire spectrum, but none of them have survived. So hemoperfusion, was discussed by everybody, it's a time sensitive agent. So the moment it crosses, and these patients, I was described, they generally take it with alcohol and they're found unresponsive. I've seen a patient, M pharmacy patient. He literally told us that, no, I have consumed Paraquat to die. I have read the whole literature and I drank the whole bottle. So whatever you want to do, he was abusing us, and he said he asked us to go to hell, and he said that I'll see you there soon. So
we have seen one businessman. He said friends in business cheated, and I think he read thoroughly about all poisons and he consumed. And family got him to hospital. Initially, as usual, like he was okay. He was maintaining everything okay. But he said next day or third day, he requested, slowly I can feel I'm getting bit breathless, and I know I've taken this much. I'm not going to survive. Don't do anything. At least whatever time I have, I want to spend with my family. So he took Lama and went. He literally begged that he wanted Lama. At least in ICU, you don't allow my family, so I want to be with my family. So he left Lama. He must have died. He was only like 35 or something, under 40 age. So if somebody wants, I think they read thoroughly and then take, and they know what's going to happen. Definitely die any. And he said he didn't want to die immediately. He wanted some time with family. అందుకనే ఇది తీసుకున్నానని చెప్పాడు.
And a lot of other young people, they take it with alcohol. So if we go by Western or whatever literature that we have, it will be very difficult for us to identify patients who will survive or who will not survive. So it's a very difficult situation for us here in India.
Thank you very much. Thanks, Chetan. Thanks for active participation. Hope we can end the session right now.
జక్కిన శ్రీనివాస్ మనం ఫోన్ చేద్దాం ఎమర్జెన్సీ అని. జక్కిన
Thank you,
శ్రీనివాస్
sir.
ఎక్కువ పెట్టాడు అన్నారు కదా.
సార్
జక్కిన శ్రీనివాస్
శ్రీను వచ్చారు సార్ లైన్ లోకి.
తెలుసు, నేను విన్నాను. ఎక్కువ పెట్టిన దానికోసం ఏం చెప్పాడని
చెప్పలేదు అది. మరి అంటే నేనేమైనా బై మిస్టేక్.
ఓకే, థ్యాంక్స్.
సరే సార్, థ్యాంక్ యూ. థ్యాంక్స్ అలాట్.
Thank you, sir.